Hi, it's Dr. Ronald Lett. I'd like to present the lecture on extremity injuries, which is part of our trauma team training course. Extremity injuries, like all injuries, is involved and managed within the initial assessment process. Airway, breathing, and then you get to circulation. You must control bleeding from extremity wounds. In secondary survey, you may have non-bleeding wounds and fractures. These need to be identified and treated. You need to splint the fractures and dress the wounds. What is the history? How did the injury happen? This can raise suspicion of a fracture. If it's a high-energy injury, this raises the suspicion for fracture. You need to know about blood at the scene of the injury. This will help determine the need for transfusion. Is there exposed bone? An open fracture requires surgical toilet. Movement of extremities can be helpful. Fracture is unlikely in a limb that is moving spontaneously with full range of motion. Exceptions are distal forearm injuries and fractures around the ankle joint. Initial extremity exam is limited to looking and feeling. The patient is exposed with complete removal of clothing. Beware of chilling the patient, even in the tropics. What do you look for on inspection? Color, deformity, open wounds, active range of motion. When you palpate or feel the wound or the extremity, is there heat? Is there a temperature warmth suggesting abscess or infection? What are the pulses? Is there tenderness? Crepitation? Sensation? Are the nerves functional? What's the motor function? Document weakness before you carry on with further treatment. Immediately stabilize extremities in correct alignment under suitable analgesia. Maintain circulation to the extremity. Prevent injury and skin necrosis. Prevent damage of peripheral nerves and vessels. Deformed injured limbs should be realigned to a more normal position before transport for definitive care. Careful. Pad bony prominences to prevent soft tissue irritation, pain, and even infection. Avoid tight circumferential bandages. Remove rings and bracelets on injured limbs. Adequate hydration is essential for injured limb perfusion. You can splint the upper limb, or you can put them in a sling. Notice here's a splint of the lower extremity that's not good enough. You should immobilize the joint above and the joint below any fracture that you're trying to immobilize. If there's a major fracture, it's associated with other fractures or soft tissue injuries, and they should be looked for. Frequently missed fractures. Head of the humerus, head of the radius at the elbow, the scaphoid bone, hip, upper fibula, and heel bone. Assess for life-threatening injuries. You do your initial care, your dressings, your splints, your fractures, but remember to deal with the airway, breathing, and circulation first. Pelvic fracture happens in high-energy injury. It's associated with significant blood loss. It also can be involved with injury to the urethra. Femur fracture may result in a loss of 40% of the blood volume, 2 to 3 liters of blood. Together with other fractures or injuries, blood loss can lead to death. Open fractures. Beware of the blood loss that is not noticed. How much blood has been lost? Evaluate the patient's hemodynamic status. Open fractures can be complicated by systemic sepsis in the short term. They can be complicated by osteomyelitis in the long term. Therefore, they require urgent surgical toilet. Traumatic amputations occur with very severe forces. There's open blood vessels which can exsanguinate the patient. How much blood can you lose with a fracture? You can lose 2 liters into the chest. You can lose half a liter with the humerus, a quarter of a liter with the radius and ulna, 2 liters with the pelvis, 1 liter with the tibia, 1.5 liters with the femur. Pelvic fracture management. Again, initial assessment, primary survey with resuscitation, secondary survey and transfer for definitive care. Some pelvic fractures, the major treatment is just transfusion. External fixation can immobilize the fracture and oppose the bony elements that are bleeding. External tamponade with a bed sheet can be helpful. Assess limb-threatening injuries. Is there a vascular injury? Is there nerve injury? Are there open fractures? Vascular injuries. Beware of knee or hip dislocation, which may be associated with a vascular injury. These dislocations can damage blood vessels. Check the pulses distal to any fracture or dislocation and make sure the limb is warm. Nerve injuries. They should be documented. Reduction in splinting is the only treatment that should occur in the initial assessment, but this will protect nerves. If extremity injury is isolated, refer the patient for assessment and care. Once again, open fractures can lead to osteomyelitis, disability, and amputation. Early surgical toilet is important. These fractures can lead to significant blood loss. There can be concealed blood loss in closed fractures. Open fracture is a surgical emergency. At treatment of an open fracture, control the hemorrhage. Remove gross debris. Copious irrigation. Prevent further contamination. Align with splints 1 joint above and below. Check pulses before and after alignment. Antibiotics and tetanus prophylaxis are necessary. Compartment syndrome. Crush injuries with fracture of the tibia are particularly prone to this problem. Pain is out of proportion to the injury. The caregiver can also cause a compartment syndrome if they apply circumferential bandages or casts to a swollen or swelling limb. Compartment syndrome occurs when excessive soft tissue swelling around the fracture threatens limb tissue viability. The goal is to diagnose and treat vascular injuries before the 5 Ps develop. Do not use the 5 Ps, pain, pallor, pulselessness, paresthesia, and paralysis, for a diagnosis. They are late signs of untreated compartment syndrome. Signs of impending compartment syndrome include severe pain despite analgesia, requests for more analgesics, severe swelling and tense tissue over the fracture, excessive pain with movement of fingers or toes. What is the care for compartment syndrome? Fasciotomy. Incise the skin and the fascia over the affected compartment and allow the muscles to bulge through the incision. If it's due to plaster of Paris cast, cut the cast, but you split all layers of the POP, including all internal padding. Never put a complete unsplit cylinder cast on a freshly fractured wound or operated limb. This is where splints are preferable. After 1 to 2 weeks, a cast can usually be applied for ongoing fracture management. Extremity injuries. The first priority is primary survey. Early attention to life-threatening injuries, including pelvis, femur, and open fractures, is necessary to control hemorrhage. Later attention to limb-threatening injuries is part of the secondary survey. Beware of vascular and nerve injuries and compartment syndrome.